Good morning to all. In the series of autoimmune hepatitis lectures, my topic is lack of complete biochemical response in autoimmune hepatitis and its effect on outcome. So I will be covering this topic in diagnosis and workup, management, biochemical response, predictors of response, non-invasive markers of response, microbiomes in responder versus non-responders, outcomes in responder, and conclusion with future perspectives. So coming to how to diagnose autoimmune hepatitis, it is being diagnosed with simplified autoimmune score and with ANA autoimmune markers. If they are present in 1 is to 40 titers plus 1, 1 is to 80 plus 2, LKM plus 2 and SLA plus 2. Serum IgG more than 1.1 times of limit given 2 markers, and histological findings typical are 0.2 and compatible are 0.1. Negative should be the markers of hepatitis B and C, and we define autoimmune hepatitis as a definite AIH when the score is more than equal to 7 and probable AIH when the score is more than equal to 6. So different autoantibodies available in autoimmune hepatitis. ANA specifically present in type 1 autoimmune hepatitis, but what is important is it is a typical of AH1 and coexisting with anti-SMA is 50% of cases. So 50% of the patient may have only ANA being as a positive markers. Also anti-LKM1 and LT-LC1, the titers of these autoimmune markers correlate with the disease activity. So when the patient is in have clinical presentation of severe autoimmune hepatitis, they might have anti-LKM and anti-LC1 positive. However, in the severe autoimmune hepatitis, sometimes falsely autoimmune markers can be negative in the initial stage, as well as IgG is also not that much raised in the initial stage. So a diagnostic algorithm, when the patient is suspected to have autoimmune hepatitis and have raised AST and ALT with IgG, and we have excluded other biomarkers, we go for the autoimmune markers, and if they are negative, then we see for the other autoimmune markers SLA, PNK, AMA, and if they are all negative, and then otherwise we also have to go for the biopsy, and biopsy if the features are typical of interface hepatitis and lymphoplasmacytic infiltrates, we label as AH, and if the biopsy is showing bile duct injury or loss, then we see for the PSC and PBC as a associated overlap syndrome or autoimmune sclerosing cholangitis if the markers and biochemical markers are also raised. So first line treatment of AH is steroids. In the dose is 0.1 mg per kg, and in the induction phase, steroid followed by azathioprine if the bilirubin is less than 3, and maintenance phase is given with steroid after tapering the steroid in the initial stage, and we add on to azathioprine. In the severe autoimmune hepatitis, we do not use budesonide, we do not use azathioprine, and we start with the steroid 60 mg or 1 mg per kg, and we assess response in 7 days. If the or transaminases decreases by more than 50%, we say it is a response, and in otherwise autoimmune hepatitis, we see the response at 4 weeks if the patient is following in the OPD basis. So if we in the normal autoimmune hepatitis without severe autoimmune hepatitis, we see response at 4 weeks or otherwise 7 days if it is severe autoimmune hepatitis. So there have been by the International Autoimmune Hepatitis Group, the response definition was given. Complete biochemical response is defined as the normalization of serum transaminases and IgG below the upper normal limit at 6 months of time. It is said complete biochemical response. Insufficient response when the response is there more than 50%, but still it is not normalized. Non-response if the transaminases are less than, there is a decline of less than 50%. Remission is diagnosed when the histological activity index is persisting less than 4/18, or intolerance to treatment when there is a side effect developed to the drug. So again, this is a diagrammatical representation that 4 weeks if the AST and LT hasn't gone down by more than 50%, it is considered as a non-response, and a complete biochemical response is assessed at 6 months with the decrease of AST LT less than ULN or upper limit of normal, and IgG should be at the less than 1.1 times. So biochemical remission or response is important because it is the only important predictor of outcome in autoimmune hepatitis in the future. It includes normalization of serum transaminases and IgG. It is also only independent predictor of histological fibrosis regression. So if we see response at 4 weeks, the patient who has less than 50% decrease in transaminases and are compared with more than 50% decrease in transaminases, we can clearly see that the liver-related death are more in patients who do not have achieved the normalization or decrease in the transaminases at 4 weeks. Similarly, at the 6 months and in the future also, the patient who did not develop biochemical response had higher liver-related death or transplant need of transplant as compared to those patients who had achieved biochemical response in the future. So what are the biomarkers and non-invasive tests associated with outcomes? So with the disease in the preclinical phase, the markers like T regulatory cell, IL-17, they are present in the preclinical phase. In the clinical presentation, we have ADA, ferritin, vitamin D level, and TGF beta and B cell activating factors. In the remission, we have CK18, DNase level, ASGPR, FOXP3, and in the relapse also CD74 levels are seen. So other biochemical tests in other non-invasive tests in autoimmune hepatitis, we see that ELF score has a diagnostic accuracy in the patient who had more than F3 fibrosis, more than equal to F3 fibrosis. The ELF score was 10.6, and as compared to a patient who had F2 or F1 fibrosis, and ELF score directly correlated with the outcomes in patients with having autoimmune hepatitis and significant fibrosis. Non-invasive markers are also important in the monitoring of the disease course in autoimmune hepatitis, and this study showed that 131 liver biopsies were assessed at the 2 times, at the start also and after the treatment completion, and they showed that the patient who has biochemical remission, there is a decrease in the LSM as compared to the patient who did not develop biochemical remission. They had progressively increased liver stiffness measurement. Also, the patient who had higher degree of fibrosis, F3 or F4, they have rapid decline of LSM with the treatment completion and the response to steroids as compared to patient who has F2 or F1 fibrosis. So another study, Spanish study, which included 11 Spanish centers, and it assessed non-invasive prediction of outcomes in autoimmune hepatitis, and they took patients, 132 patients at diagnosis with cirrhosis and with the portal hypertension, and they followed these patients, and they found that patient who had cirrhosis, LSM value was able to predict remission better as compared to the patient who was not in remission. So the cutoff was 12.5 in the patient who had remission 43%, and as compared to 61% patient who had raised cutoff. Similarly, 14 kilopascal and 16 kilopascal if we compare these groups in the patient in remission and not in remission. So but only 33 to 49% of patients had LSM above the proposed cutoff for AIH-related cirrhosis. For non-invasive markers in diagnosis of portal hypertension in autoimmune hepatitis, in this graph they also showed that patient with portal hypertension along with cirrhosis has a 60% chance of predicting with the cutoff of 12.5 as compared to 14 and 16. Both were significantly discriminated the patient who had portal hypertension with AIH as compared to the patient who did not had portal hypertension as LSM. This graph showed the patient who were followed up. Later on, the LSM value did not significantly predicted the course of disease in the autoimmune hepatitis apart from the initial 6 to 12 months. So the patient who has achieved response in the 6 months, then they can be informative, but after the 12 months or 1 year, 2 years, they are the same. So the study concluded LSM cutoff points do not have a good discriminative capacity for the diagnosis of AIH-related cirrhosis, especially long term after treatment initiation. Another study This is a large retrospective study which included 2,559 patients, and it showed lack of complete biochemical response in autoimmune hepatitis leads to adverse outcomes. So study this was initiated by the International Autoimmune Hepatitis Group, and in 1700 patients the follow-up was available, and 90% had completed the study. This study showed the patient who has liver-related death or need for transplant was seen that the patient almost 44% has cirrhosis as compared to the patient who survived 23%. So the presence of cirrhosis is a marker in patient of autoimmune hepatitis of the liver-related death or transplant or poor outcomes. Similarly, the MELD score, high MELD score, no normalization of ALT or AST in less than 6 months, that is complete biochemical response. The patient who had not achieved this was also shown that is a marker that it is related to liver related death. This graph shows the patient, again shows the patient who has cirrhosis. This is a red line graph. The survival was less as compared to the patient who, the blue line, which the patient who had no cirrhosis. The patient who has achieved complete biochemical response, they have good survival. Similarly, the patient who has normalization of AST or ALT less than 6 months, they had a good survival. So, what are the factors associated with cirrhosis development in patient with autoimmune hepatitis? This showed that presence of PBC, PSC or overlap syndrome or presence of other invariant diseases and lack of complete biochemical response is associated with cirrhosis development in future in patient of autoimmune hepatitis. This was shown in the multivariate analysis and the p-value was also significant. The factors associated with lack of complete biochemical response within 6 months in patient with autoimmune hepatitis, the factors associated were cirrhosis, SMA positive, ALP positive, IgG.
Satender, can you go back to previous slide?
Yes.
So the rate of development of cirrhosis is in non-responders?
So rate of development of cirrhosis were 20% in patient over
per year.
So per year they I did not see to it, sir.
That's a very important data. In 20 years you develop about 20%, maybe 10% versus 50%.
20% versus 50%. They have shown in the follow-up time of years, but the discrete value was not able to find the how much the discrete they have.
We should read it more carefully. We don't have data on non-responders developing cirrhosis.
Yes, sir. So another study by Brazil that showed that clinical and biochemical but they were able to find in the last 2,500 patients that this is important in predicting the patient who had who had complete biochemical response or not. Maybe the severe autoimmune hepatitis has more raised IgG levels. That is maybe the reason. So this Brazil study that included only around 150 patients, and they showed that biochemical response remission 1 year after diagnosis occurred in 55% patient, and histological remission rate was 30%. Cirrhosis at disease onset, along with older age and reduced 1 year biochemical remission was associated with the poor response. Another studies, older studies, a few studies have shown that patient with younger age, they were also as a predisposed to have non-complete biochemical response. So this study also correlated with the previous study that older age is associated with the reduced biochemical remission. The presence of ascites as disease onset was associated with the higher AST and ALT, and higher MELD score was associated with the poor biochemical response. So any microbiome is related to, in microbiome in AH related to the biochemical response or not. So few studies are there which showed, all studies showed there is a reduced diversity of microbiome in autoimmune hepatitis. And if we go to the specific study, then this study shows that compared to healthy control, decrease in Faecalibacterium and increase in Veillonella, and the facultative anaerobic genera Streptococcus and Lactobacillus was detected, and lack of Bifidobacterium was associated with failure to achieve remission in autoimmune hepatitis. So Bifidobacterium is considered as a good bacteria. If there is less, then the risk of non-achievement of response is also less. This graph further shows the patient who has a higher abundance of bifidobacterium, they have achieved response. And this graph showed the patient who has Villanella in the stool, they had higher ALT and AST, suggestive of these patients might have severe autoimmune hepatitis. The presence of Villanella also suggests that patient might have severe autoimmune hepatitis. So only biochemical response is sufficient, or histological response is important. So this study showed that 46 patients, they correlated with the 55 patients, and they assessed the histological response is important or not. So they, on multivariate analysis, they showed the patient who has persistent histological activity were independently associated with the death, need for transplant in the future, as compared to the patient who has achieved histological remission. So along with biochemical remission, histological remission is also very important to have the future normal course or prevention of liver related mortality. So this Canadian study, it has taken 691 patients, and it assessed treatment response and clinical event free survival in autoimmune hepatitis, and they evaluated this in 11 Canadian centers, and with a mean age of 49 years and median follow of 6 years. They showed that ALT normalization occurred in 63.8% of the cohort by 12 months, and they showed that the patient who has a no cirrhosis as compared to cirrhosis, the patient who has a normal ALT in patient of cirrhosis has a better response or better ALT. Another same study showed the presence of female gender, age, and diagnosis by 10 years and cirrhosis were independently associated with the poor response. So cirrhosis status was associated with reduced chance of normalization at 12 months, baseline total bilirubin, AST and ALT level, IgG, as well as the initial prednisolone did not predict average ALT reduction. And at baseline, older age, cirrhosis, and elevated bilirubin increase the risk of clinical event. So older age, cirrhosis, and higher MELD or bilirubin were associated with the poor response in autoimmune hepatitis in the future clinical event in autoimmune hepatitis. So coming to another study, they assessed the autoimmune markers. Are they responsible for the response or not? So this study included 282 patients, and they showed 59 patients had sustained response as compared to 41 who had incomplete or absent response, and they showed the presence of SMA antibody, anti-LC1. They were associated with the poor response to steroid or medical therapy in autoimmune hepatitis. So along with biochemical, clinical, and autoimmune markers, some are also responsible for predicting response or not. Another study which showed how to predict response, who will respond to steroid or not, and this is a multi-center study. They used the Surfasa score, INR, bilirubin, and they showed MELD more than 26 had a sensitivity of 85% and specificity of 78% for the prediction of non-response. Similarly, in ILBS, we also had assessed these flare of autoimmune hepatitis, and we showed that patient of advanced age, MELD more than 27, presence of hepatic encephalopathy and advanced fibrosis, they had unfavorable response to corticosteroid therapy. So to conclude, biochemical remission is the best predictor of long-term outcomes in autoimmune hepatitis. MELD more than 27, presence of advanced fibrosis, presence of cirrhosis are poor predictor of response to therapy. Fibroscan and other non-invasive markers need validation in large cohort of patients. Histological remission is important for preventing relapse in future. Change in microbiome can trigger predisposition for autoimmune liver disease, but however, with the severity of autoimmune liver disease, the microbiome studies were limited. So in future, we need therapy for a patient with severe autoimmune hepatitis and MELD more than 27 having no transplant option. Large ILBS data needs to be analyzed for response prediction. Non-invasive tests and biomarkers should be validated in Indian population and defining response or relapse to therapy. Studies should investigate the microbial domain to understand how treatment changes the microbiome. So we have, with the limitation, we have taken this study this month only. We have passed from the department the efficacy and safety of therapeutic plasma exchange versus standard medical therapy in severe autoimmune hepatitis. Thank you.